Welcome, everyone. My name is Amber Ham. I am the Training and Outreach Coordinator with KYSPIN. I'm so excited that you are able to join us today to discuss the Medicaid waivers. At this time, I'm going to turn it over to Pam Smith.
Hi, thank you all for joining us. We are going to give a brief update about what's been going on with waivers, and then hopefully we'll have time to be able to take some questions. I am not going to go on camera right now because I'll tell you, I've got so many things going on. I think I would be looking at the opposite screen because trying to look at the presentation plus where the camera is, it's a little much for my multitasking. So we'll go ahead and get started. I think we will get started. Okay, there we go. So first thing we're going to talk about is the 1915C waiver updates. Also talk a little bit about the Children's Waiver Feasibility Study progress. And lastly, our 1915I State Plan Amendment for individuals with serious mental illness. So first up, those 1915C waiver updates. Just to remind you, we have the 6 waivers. So we have both the waivers focusing on acquired brain injury. So acquired brain injury, what we call acute, and acquired brain injury long-term care. We have our largest waiver, the home and community-based waiver, that serves individuals that are aged or that have physical disabilities. Our Model 2 waiver, which is for our technology-dependent individuals. So these are individuals that are ventilator dependent or are on an active weaning program to come off the ventilator. Our Michelle P. waiver and supports for community living waiver that serve individuals with developmental disabilities and intellectual disabilities. And the main difference in the two of those, there's more services in SCL, and SCL does have a residential component. So what has been happening with our 1915 C waivers? So first off, everybody will focus on Appendix K. What is Appendix K? So it's an extra appendix of the 1915 C waiver applications that allows states to make temporary changes to waiver programs during emergency situations. When I first started this job, I didn't know what Appendix K was. Over the last 3 years, I have submitted an Appendix K for a pandemic, for COVID, as well as for 2 natural disasters. So the flooding, unprecedented flooding that we had, as well as the tornadoes that we had. We are allowed to submit modifications to those. So there have been several iterations of those. So from March of 2020 to July of 23, we submitted 5 COVID-19 related Appendix K amendments. And then again, as I mentioned, thrown in there, we had the one for the flood as well as the natural disasters. In August of 23, CMS sent out guidance that the state's given us direction on how to permanently continue any chosen Appendix K flexibilities. Because even though it was an unprecedented time and it was scary, we learned a lot through the pandemic, and some of those changes we wanted to be able to continue those flexibilities. So in August and September, we were working very diligently to update all 6 of the waivers to write in several flexibilities from Appendix K permanently into the waivers. We held a public comment period from the end of September, so September 27th to October 27th. We had a 30-day public comment period where individuals were able to submit comments on all of the waiver applications. We had a deadline of November the 11th to submit all of those applications to CMS. We submitted the Model 2 waiver on November the 3rd, and we submitted all 5 of the other waivers on November the 9th. So we beat that deadline to ensure that we can continue with the Appendix K flexibilities that are in place right now and make others permanent, which we'll go over those in just a second. And so now it basically is in the hands of CMS. So all current Appendix K flexibilities remain in place until the submitted waivers are approved and have a new effective date. However, we are encouraging individuals not to wait until the clock is out and we say, okay, you have to stop doing some of these things now, or you need to change things now. We encourage individuals really to go back to the root of that person-centered planning and thinking about, what's best to support the individual and how best to move forward. So which flexibilities are going to be permanent? So we are going to continue to allow telehealth as a component of case management, counseling, and therapy. Telehealth, to some extent, always was a component of case management. There's always been a provision that has allowed some of the case managers to do, a phone contact with individuals like every other month or at different points in time, and then there were the face-to-face visits required. We are really encouraging those face-to-face visits to resume, and they will be a requirement going forward, that there will have to be at least a quarterly face-to-face visit. We're working on all of that now, and to make that consistent, because I realize it was different based on some of the waivers, which one you were on. But there's so much value in seeing somebody face-to-face. Somebody can tell you something over the phone and you not really know. They can control what you can see if you're using, a platform where you can have face-to-face, eyes on the person, but you don't always see the environment. You don't smell the environment. You can't tell that it took somebody, 15 minutes to get to the door. So there's just so much value that we get in those face-to-face visits. Counseling and therapy is the same way. We're not encouraging all of them to go to telehealth. However, we found value in, perhaps one of my favorite stories is with behavioral health, is when an individual was escalating and the behavior support specialist was able to get on the phone with them and was able to talk things out with them and to calm them down. And it prevented that individual having to go to a higher level of care. So we've seen the value in telehealth. We have expanded case management provider qualifications. We found that during the pandemic, when it was very difficult to hire anyone, as well as looking at what other states have done, that we were able to expand those case management provider qualifications. We reduced the age requirement for respite personal assistants, attendant care, and residential staff from 21 to 18. What this allowed is for some of our individuals that are going to college to be in this field, that are have maybe just graduated from high school but participated in the health occupations vocational classes. It allowed them to go ahead and get their foot in the door and start getting some experience to provide some of these services, and really helps us to begin a foundation to grow our workforce. We are going to continue allowing access to respite for participants receiving residential support level 2 in SCL. So this is our individuals that live in a family with a family home provider or an adult foster home. So these individuals really become part of that individual's family. And as such, we wanted to allow the individuals that live with them to have access to respite on an ongoing basis. Allowing limited waiver services to be provided in acute hospital settings under extraordinary circumstances. And I want to stress with this, it really is extraordinary circumstances. So this is for the individual that, say, for example, does not have a communication device and cannot communicate their needs, their wants. I'm hurting, I'm hungry. That it allows for someone to be with them. Those do have to be prior authorized and do have to be requested as soon as I realize sometimes they may not be able to be pre-scheduled, but as soon as they know that that's going to have to be provided, we encourage the case manager to reach out to us to provide that information so that we can discuss those services. Not meant to replace if there's someone that has natural supports or family members that are able to be there with the individual. It should not be replacing that, and it should not be replacing any of the care that a hospital is expected to provide. We expanded residential in the acquired brain injury programs to allow up to 5 participants per house. This is when the residential setting is capable of handling that many individuals, and it is the person's choice that they would want to live with up to that many individuals. And then the most important one, I think, was maintaining the Appendix K rate increases for all waiver services. So those will remain in place until the permanent rate changes from the rate methodology study, until those go into place. So there will again be another round of waivers going out for public comment when we are able to implement those permanent rate changes. So what guided the proposed policy decisions? You know, it was a lot to think about. There was a lot that happened during Appendix K. There was a lot of changes that we made. So what did we go through to decide what we wanted to keep versus what was going to sunset? Some of the factors of these policy decisions, and probably the most important, was the health, safety, and well-being of our program participants. Where it was best to return to in-person service delivery. We've had a lot of individuals say, well, why can't we just do everything telehealth, or why can't we do all services via telehealth? You know, individuals on this program meet nursing facility level of care, and so there really needs to be that hands-on, eyes-on component, while balancing it with some services that can be provided through telehealth. But in most cases, in-person service delivery it's important for socialization. It's important for, I think, the well-being of the individuals. And I think it helps establish the relationships between our caregivers and our individuals. We had to look at when a policy had to go back to normal because of standing federal requirements. We had to look at where the emergency-based allowances were no longer needed. And we had to balance out, how do we continue to sustain, maintain, and grow our existing HCBS provider network? Legally responsible individual review. So we temporarily suspended the immediate family member review process for participant-directed services employees during COVID-19 public health emergency. This process will remain suspended until the effective date of the updated waiver applications. And that will, right now, that date is April 1st. However, it will be based on CMS's review. It will not be any earlier than that date, but if CMS delays the approval, it could be after that date. So this is something that we will continue to communicate with agencies and with individuals. Individuals hired while the suspension is in effect and who must go through the review process can continue to work just like they have been working until the review is complete. Reviews will take place at the time of the participant's recertification, but again, that will not be until we have the effective date of the updated waiver applications, and we will communicate that out at least 60 days ahead of time so that agencies and families have the opportunity to be prepared to provide any information. When the review process resumes, however, we've made one small change in that it's only legally responsible individuals that must be reviewed. Any family member who is not also a legally responsible individual does not need to be reviewed. So who is that legally responsible individual? So for a minor child, someone younger than 18, that includes a parent, a step parent, an adoptive parent, or a court-appointed legal guardian. For our adults over the age of 18, it is a spouse, or their court-appointed legal guardian. Why do we have to review legally responsible individuals? So per Medicaid or Medicare, sorry, CMS, so Center for Medicare and Medicaid Services, when PDS employees are allowed to be hired and provide services to the participant, which they are legally responsible, the state must define the types of LRIs who may be hired, and the service provided must meet the definition of extraordinary care. The CMS definition of extraordinary care is that it is care exceeding the range of activities that a legally responsible individual would ordinarily perform in the household on behalf of a person without a disability or a chronic illness of the same age, and which are necessary to assure the health and welfare of the participant and avoid institutionalization. So again, additional details and training will be made available before that process resumes. So what are our next steps? The waiver amendments, we will continue the flexibilities that were incorporated in the amended waiver applications and submitted to CMS. We are finalizing the responses to the public comments we received. I believe we received, I know it was well over 150. I can't remember the final count on the responses. And so we are in the final cleanup phase of those and organization phase of that document. So that will be coming out very soon. We will continue to work with CMS to get the waivers updated and to get them approved. So the next step will be, as CMS reviews those, they typically send requests for information. So we will work very closely with CMS to respond to those timely and to answer any questions that they have. The discontinued flexibilities end on the effective date of the waiver. So any of those flexibilities that we did not write into the waiver and that we're not continuing, those will end if the waivers, the effective date that we have right now on the waivers of 4/1, if that stands, then those flexibilities that did not continue, so those that I did not review earlier, would end on 3/31. We have begun working on our Kentucky administrative regulations to now align with the updated waiver applications. And we are working on, we'll be working on future waiver updates to incorporate the final payment rates that were determined out of the rate study. The Children's Waiver Feasibility Study. So the purpose of this study was to determine how children with severe emotional disabilities, intellectual disabilities, or related conditions, including children with the autism spectrum disorder, can have improved access to services and supports that would allow them to remain in their homes and communities. The population of the study was individuals aged 0 to 21. We looked at institutional level of care, so children who need a level of care that's provided in an acute care hospital or an immediate care facility. We looked at, again, the conditions were severe emotional disability, so any clinically significant disorder of thought, mood, perception, orientation, memory, or behavior that is listed in the current edition of the American Psychiatric Association's Diagnostic and Statistical Manual of Disorders. A mouthful. Intellectual disabilities and related conditions. So these are children who require physical or environmental management or rehabilitation, a planned program of active treatment, a protected environment, and have substantial deficits in adaptive functioning that without ongoing support limit functioning in one or more activities of daily living. And autism spectrum disorder, which is a developmental disability that can cause significant social, communication, and behavioral challenges, including autistic disorder, pervasive developmental disorder not otherwise specified, and Asperger's syndrome. So what has happened to date? We have completed family and caregiver focus groups, a family and caregiver survey, and comparative state research. We are continuing to work with the stakeholder advisory group. We are going to be doing some targeted state interviews with some of the comparative states that we've looked at. We are looking at our Medicaid data, as well as a provider survey that was just recently launched to seek the interest, to see the interest of our current providers who may be interested in becoming a provider to this population. Upcoming is what we always have to do. We're going to have to determine budgetary impact, and then a final report will be issued that'll include a summary of the activities, findings, and recommendations. Again, this was a feasibility study, so there's not been a decision about whether or not this will be a new waiver or what services would be offered in that waiver. It would require funding approved by the legislature in the state's biennial budget. Okay. The last one is the 1915I State Plan Amendment. So what is a state plan amendment? You all are used to hearing us talk about the 1915C waivers. This is a state plan amendment allows us to establish a new Medicaid eligibility group to receive home and community-based services, define the supports and services included in the benefit, target a program in its menu of services to one or more populations using needs-based eligibility criteria. We offer the benefit statewide to eligible individuals. When services are offered within the Medicaid state plan, they are available statewide and there are no cap slots. So there's not, for example, with Michelle P, the 10,500, there's with a state plan amendment, you do not have a set number of slots. And it allows us to offer HCBS to people who do not yet meet an institutional level of care, or, for example, would not qualify for a nursing home. So how did we decide that we needed this 1915 ISPA? So Senate Joint Resolution 72 directed the Cabinet for Health and Human Services to create a Medicaid program to address current needs of individuals living with severe mental illness in Kentucky. The resolution stated the need for supported housing, supported employment, and medical respite. Additional indication of behavioral health needs are interviews with multiple behavioral health advocates and stakeholders to identify additional needs for individuals living with SMI and substance use disorder. I will say this state plan amendment we are doing in conjunction with an 1115 waiver that our behavioral health group is also completing right now. So we've done, so far we've done our policy review and comparative state research. We've held targeted stakeholder and peer state interviews. We've held multiple strategic design sessions. We are currently in the process of drafting the 1915 ISPA components. And next month, we are going to be conducting information sessions across Kentucky. Following that, we will finalize the waiver and it will be placed out for public comment, similar to what just happened with the 6 1915C waivers. So these are our current SPA town halls. I will tell you that the Northern Kentucky one, I was not thinking about dates at the time and did not realize, didn't make the coordination that the 12th of December was going to be Inauguration Day. So we're going to be shifting that one slightly. So we're working on, I'll get that date out. It will happen around still in the same time frame. But we're working with our location and to get that set. But we will still be having a session in Northern Kentucky. Our Louisville location, we are finalizing the last details on that, and that will be sent out. We also will offer, 2 of the locations will offer virtual attendance options, and we will record at least one of those sessions. You can email Medicaid public comment at ky.gov for details. We also will be sharing that information out again, especially with the updated date that's going to replace the 12th. the Louisville location and the information on the virtual attendance options. You will be allowed to ask questions at those town halls, and we will incorporate the comments that we receive in with any of the development and the public comment in general with the development of the state plan. And then, so our last slide is kind of our standard slide about where you can get the links for how you can get information about Appendix K and COVID-19, just general waiver, and then everything that's really that is going on with us right now. To get an email updates or submit a comment, there's the link to self-subscribe, or you can also email Medicaid public comment and we can get you on those distribution lists. Encourage you to follow us on social media to get connected, to get those updates. We do try to push out a lot of information and try to stay in contact with individuals, try to keep the communication open. And I always encourage anybody that, because I always think of myself an example. I'll be in a meeting and I'll think, okay, I don't have any questions. And then, you know, the meeting's over and I have a question or I have a comment. So I encourage you always to use that Medicaid public comment email. We do look at every single email that comes into that box. That is the end of the presentation. And I believe, Rhonda, we had Kelly got you I think we got you the deck that we could to share out. Is that right?
Yes, absolutely. And we do have, I put it in the chat, and then we will also follow up after before the week's out and email to all attendees the link to that if you don't have a chance to click on that to access it. We did have a couple of questions, if that's okay. One thing that we'll do is, again, we're not going to talk about individual situations on here, but we did have a question. Is that okay, Pam? If time for a few questions?
Absolutely. Yes, that's fine.
Well, and first and foremost, I have to thank you all so much because you all are not only to do webinars to keep us all up to date and help us as we go through this journey together, but individually working and helping, and especially with the unwinding of Medicaid. You all have been helping with many families and helping us help them. So we are very grateful. I wanted to just put that out there because you all have helped us a whole lot. We do have a question. Will agency brokers be allowed to inform clients or representatives about the Michelle P. waiver raises? We had asked them about that, but they said they couldn't offer raise info.
Okay.
So,
yes, so at any time now, and we recently, I guess it's been out there for a little bit, but previously we had always had the rates were just in the regulations. Well, so much changed with you know, what we were allowed to do with COVID and what with the legislative, the increases in state fiscal year 23 and 24, that we've created an HCBS waiver fee schedule. So those are actually posted on our website. So the rates are out there, and so at any point in time, the individuals can be, you know, made aware of what the max is that they can pay their individuals. Now, I always encourage people too, though, to remember, you know, when talking to them, is that you know, you do not, because there's a certain max. Obviously, you can pay up to that, but if you can always pay your employees based on what you feel like their skill level is, and so they have the flexibility to go, you know, anywhere within that range. Now, they have to pay above minimum, what they can't pay below minimum wage, but they also have the ability to pay up anywhere up to that maximum amount.
Thank you. And one of the questions, so the rate study, and you may have, was the rate study released? I can't remember if you had
It,
mentioned
it
that.
has not. So it is with review with individuals much higher than me in the cabinet. So, but it will be made available. The results will be made available. It will be in the, we'll have to update the waivers again. So that's where our reference, we'll do another public comment period when we have to put those, put that information in the waiver. But yeah, so it will be released. And why is it not being released? I don't really have a good answer other than, I mean, it's been in review. Everyone, is looking at that, and I'll hope to have something out soon. But we're as anxious as everybody else, I think, to have that out and to make sure we get that right.
Well, and any of those links, the upcoming town halls, any of that information that we could share out as well, and any of the links of the current rates that are available, we can share that with everyone when we send out the link to the slide deck that you had shared with us. We can send that all in that email to everybody that has helped as well. One of the a couple of other questions. One is, and not just like with the unwinding, but the questions that we hear from families a lot is, they may be being told at the local level with their case manager or with Department of Medicaid, they're getting mixed information or, conflicting information. And for families who are not able to get the answers, or they're getting conflicting answers, what do you suggest? What would be the next step? Because many times it may be a misunderstanding at the local level. What would you all recommend families do and individuals to get those questions answered?
So we have had individuals, they can call the help desk, and we'll put that information in the chat. Now, know that our individuals, when they answer the phone on the help desk, aren't going to be able to provide them an answer. They're going to be collecting data, because we're going to have to get that to our, we'll have to get that to the staff within the cabinet, within our team that does that. But we can facilitate getting that information. I always do not mind and have helped several individuals. I will say, though, my email sometimes is a little out of control, but you can always, you can share my information as well. And we, so if you reach out to us, we can help connect the parents or the families with the right information.
Thank you so much. And I wanted you all to share that, and especially with the help desk, because I know that, that's at the state level. And so if you're running into, you all have helped with so much and so many families, when they are getting that conflicting information or not able to get the results. So we are grateful that that is available. One of the things too, one of the questions that was kind of asked a little bit early on, it was sent to me, was is with the telehealth, being able to access the telehealth would not just be for PDS, that would be whether you're on traditional or PDS services, right?
Correct, yes. The services, yes.
Okay.
So the services that will have a telehealth component are whether you're accessing blended services, traditional, or just participant directed. Now, on the participant directed side, it's more limited, because it's really just going to be, kind of that your case manager, support broker, service advisor, whatever you call them right now. We are going to be changing that name, if it is one of the last things that I do, to be one consistent name, or maybe two consistent names, one for traditional and one for participant directed, but so that we don't have the same service that has about 6 different names. So we're trying to make that.
I would be grateful for that, because let me just tell you, that can cause you a big mess to begin with, trying to understand what everybody's talking about,
It has. Well, I've said, you can't, it happens because all of the waivers have evolved at different times, and it just kind of organically happened that way. But now when you look at them at the same time, it's like, wow, why did we do that? Didn't make sense. We need to change that. So we're trying to go back and clean up some of that, those types of things too.
Well, y'all are probably like me. I live and learn, right? It sounds good at the moment, but we adjust as we go. One of the things, I know that one question on here was, and I'm trying to keep up with stuff because everybody's much quicker than me, but one of the things on here was that some of the PDS agencies are refusing to submit the rate increase to Medicaid. So what would families, reps are requesting the rate increase for their employees, and the community mental health are saying that they can't increase to the max rate. So what should families do? Because we know it's so hard to find, as a family myself, we know it is so hard right now to find people. What would families do if the agency they're going through refuses to do that?
So we need for the families to reach out to us at that point, or to DAIL. And April, Alicia, Kelly, if one of you all help me and put the DAIL, their information in the chat there, their email address and their phone number. And then you also can use the help desk information too. They can collect that, and we can reach out to the agency and find out what the miscommunication is, or what's going on.
Thank you so much. We appreciate you all more than we can put into words. And
we appreciate you all as well. These are the things I think that help, is to being able to get the information out there and to answer the questions. So we always enjoy when we're able to collaborate with SPIN.
Well, we do too. We're a bit partial, because the more that we can spread the word and help one another, and there's not enough of us around, to get the word out so everybody gets what they need. So any way that we can assist, and I will make sure in our follow-up email, this the help desk, all of this information also will go out in our follow-up email to everyone. If you would not mind taking a moment to complete our evaluation, we value your feedback greatly. And any way that any ideas of future trainings, lunch and learn webinars, just let us know. But thank you all again so much, in your whole team, Pam, because I know there's a lot of you all that does a lot of work in helping all of us. And I put the link in the chat there to the evaluation, and we appreciate y'all and hope y'all have a wonderful day.
Thank you, Rhonda, and thank you, everybody. And if you, like I said again, if you think of something after we're done, because I'm typical of doing that, I'll remember I'll remember when I'm going down the highway at the end of the day on the way, like, man, I should have asked that. So, use those, the number and the Medicaid public comment email that's in the box. And even if you think it's silly, or you think you may be the only person that's wondering about that, we truly do value all that feedback. We use all of that feedback, and we read every single thing that we get into that box. So
absolutely. And typically I think of it when I'm so tired, I'm supposed to be going to sleep, and I can't stop thinking of questions. So. Well, you all have a great day, and we appreciate your bunches.
Thank you. You all
Bye-bye
too.
now.